The definition of endometriosis is basically the presence of the cells that are similar to the lining of the uterus cells in the wrong place. So these cells could be could present as patches of cells outside the uterus, and that's called endometriosis. When these cells exist within the muscle of the uterus, this version of endometriosis is called adenomyosis. Endometriosis is an inflammatory disease that causes scarring and pain. And the reason for this scarring and pain is that every month, when there is menstrual changes and hormonal changes, the cells of the endometriosis bleed, and the bleeding causes scarring, and the scarring can cause pain. So typically, the patients with endometriosis, they start with pelvic pain during periods or painful periods, and then gradually with time, as the disease progresses, they will start to have pain all the time, but they still have worsening pain during periods. So the cyclical pattern of the pain or the cyclical worsening of the symptoms is the key for the diagnosis or to suspect the diagnosis of endometriosis. The gold standard to diagnose endometriosis is the laparoscopy. There are other investigations that can help. For example, ultrasound scan can detect a cyst on the ovary or endometriotic cyst on the ovary, and that can lead to suspicion of severe endometriosis. MRI scan is good in detecting severe endometriosis. The accuracy of the MRI scan is between 80 to 85%. But the MRI scan and ultrasound scan often miss mild to moderate endometriosis. So the laparoscopy is still the gold key investigation to assess, diagnose, and treat endometriosis. Fibroids are not a common cause for pelvic pain. However, the fibroids is basically a smooth muscle tumor that is really firm. And when you have a firm tumor, especially if it's large, i.e. more than 4 or 5 centimeters, it can press on a nerve or press on another structure, and this pressure can cause pain. In some occasions, we have fibroids that are within the cavity of the uterus, and if that's the case, patients will get contraction-like pain, crampy pain. And that's the uterus contracts to try to push the fibroid out. And that can be really severe pain. But most of the patients with fibroids, they don't have significant pelvic pain, but they could suffer from, for example, heavy periods or pressure symptoms, like, for example, if the fibroid is pressing on the bladder, they can go to the toilet to pass urine too often, more than 8 times a day, or they can wake up at night several times to go to the toilet, or in extreme cases, the fibroid can obstruct the flow of the urine from the kidney to the bladder and by putting pressure on the ureter, but that's again very unlikely. The diagnosis of fibroid is usually made by ultrasound scan. So when the patient presents with heavy bleeding or pelvic discomfort or pressure symptoms, the first line investigation is to arrange a pelvic ultrasound scan. And then it's normally obvious on the pelvic ultrasound scan. The MRI scan is a better tool to assess the position of the fibroid. In my experience, the size of the fibroid, which almost everybody is focused on, is not the most important factor to determine the impact of the fibroid on patient symptoms and also the surgical challenges. So in my opinion, the position is more important. The position of the fibroid is more important than the size of the fibroid. For example, if you have a fibroid that is 4 centimeters on the cervix will give patients more symptoms compared to 10 centimeter fibroid on top of the uterus. Similarly, so that's the position according to whether it's in the lower uterus or higher uterus. Similarly, we should look at the fibroid, whether it's bulging into the cavity of the uterus, within the muscle of the uterus, or bulging outside the muscle of the uterus. And that can also contribute to the symptoms as well. So the fibroids that are bulging into the cavity is associated with more symptoms, even if it's not big. For example, if there is a 3 centimeter submucosal fibroid, the patient will have severe, heavy periods, which could be painful, compared to, for example, a 7 centimeter fibroid that is in the middle of the muscle of the uterus. So you can see the difference, that a bigger fibroid, but in a better position, will cause less problems. And while, for example, a 10 centimeter fibroid that's bulging outside the uterus might cause no symptoms at all. So the lower the fibroid, the more symptoms patients will get, and the more challenges we come across to treat it. And also, the more inward the fibroid, i.e. bulging into the cavity, the more difficult to treat. And the MRI scan is a better tool than ultrasound scan to assess the position of the fibroid. Pelvic pain due to endometriosis, as I said earlier, is often or has often a cyclical pattern. Either a cyclical pattern that gets worse once a month, like every month, and or it's not existing apart from certain period of time. But even when endometriosis is severe and the patient suffers from continuous pain, they will still have cyclical changes or cyclical worsening of the pain. Endometriosis pain often also gets is radiated to the front of the thighs or sometimes the back. While, for example, pelvic pain due to fibroid is more of a pressure sensation on a certain nerve or a certain organ. Therefore, the patient will feel that there is something pressing. That's what they say, or they feel heaviness in a certain area. And the pain is often positional. So sometimes if the patient lies on one side, they get more pain. If they lie to the other side, on the other side, they get less pain, and so on. Luckily, most patients with fibroids, they have insignificant endometriosis or no endometriosis, and vice versa. However, when you have fibroids and endometriosis, the management becomes more challenging. One of the important elements to remember when we deal with endometriosis is that laparoscopic surgery is the main stepping stone in treating endometriosis. Endometriosis is difficult to be assessed and visualized at open surgery. So the best way to treat endometriosis is laparoscopic surgery, because we can see it better. We can use the fine equipment to find our way to dissect the structures away from endometriosis, to excise the endometriosis. All of that is only possible by laparoscopic surgery. So open surgery I can see it as the wrong treatment, in my opinion, for most patients with endometriosis. Fibroid treatment will depend on or surgery will depend on the position and the size of the fibroid. And unfortunately, most fibroid surgery nowadays is done open rather than laparoscopic. So when you have a patient with a combination of both, my concern is that if they have open surgery, the future endometriosis surgery will be just much more challenging, because everything will be stuck together even more because of the endometriosis. And also the planes will be difficult, the surgical planes of dissection will be difficult to differentiate because of the operation to remove the fibroids. So that's if the fibroid surgery is arranged first, and if the surgery is open. Therefore, it will be better to have fibroid surgery laparoscopic if possible, so that when the patient will need to have any other operation to remove the endometriosis, it's not going to be more challenging. If we do the operations the other way around, if we need to remove the endometriosis first before fibroid, when patients have large fibroid, the fibroids can obscure the view to the pelvis or access to the pelvis. So sometimes it's not possible to remove the endometriosis first, because the large fibroids, I'm talking about like 15 centimeter, 12 centimeter large fibroids, those large fibroids can be obscuring and stopping us from accessing the pelvis to remove the endometriosis. So we often, with large fibroids, we often forced to deal with the fibroid first before dealing with the endometriosis. And that's where it comes to my first point of discussion, that if we do open surgery for those fibroids, we will just make the future laparoscopic surgery for endometriosis more challenging. So someone might ask a question. Someone might ask a question: why don't we do it both at the same time? Yes, that's possible to have surgery, laparoscopic surgery for the fibroid and endometriosis at the same time, but it can be really long operations. So imagine if you need to remove multiple fibroids and they are large, and you have to repair the uterus. Such an operation laparoscopically can take sometimes 4 or 5 hours. On top of that, if you need to do another 4 hours operation to shave the bowel and remove the endometriosis, severe endometriosis from the bowel, that will also add another 4 hours. So I think patient's body it's not easy to cope with a 9 hours, 8 hours operation. So therefore, I tend to split the surgery for those patients to be in 2 stages. But that's not applicable when it comes to moderate endometriosis or small fibroids. Then they can have all of it all in one. There are things to remember that when we deal with the endometriosis and fibroids, is that the fertility side of things is also very important. So we have to bear in mind the ovarian reserve, the age of the patient, and whether we need to, for example, freeze eggs first before we do the operation. So lots of elements to consider when we deal with a complex endometriosis, and also even more if we come across complex endometriosis and also complex fibroid situation. I always discuss all of the treatment options with patients, and the patients can select the most suitable option for them. And that most suitable option can sometimes vary according to where is that patient, particularly in their stage of life. So for example, for endometriosis, I always offer 4 treatment options. One is hormonal suppression to endometriosis. Second is laparoscopic excision of endometriosis, which is keyhole to remove the disease. Third is conceiving. Pregnancy improves symptoms of endometriosis. The 4th option is to do nothing, and that option, I think, do nothing is the worst option, because the endometriosis is a progressive disease. But I think when we discuss it with the patient, it's very useful for the patient to understand that do nothing is an option, and that is like a reassuring signal to those patients that endometriosis is benign and can be left alone as long as we understand that there is no impact of endometriosis on any vital organs. For example, if when patients have severe endometriosis, there is about 2 to 3% chance of having obstruction to the ureter, which is the tube between kidney and bladder, which can damage the kidney. So I see maybe a patient once every 2 years when they present with a dead kidney, unfortunately, when it's too late for those patients to detect the endometriosis, but that happened after years of being in agony and going rounds, different investigations, different consultations, and being referred from one specialist to another. Eventually, they think about endometriosis and they detect an affected kidney at that point. So yeah, to go back to the options of endometriosis, do nothing is an option as long as we understand and accept the impact of the possible endometriosis on any organ, and we can exclude this impact by test, laparoscopic excision of endometriosis, hormonal suppression, or conceiving. So these are the main elements for endometriosis treatment. The fibroid is kind of similar-ish. You have patients with fibroids could do nothing, again, if their symptoms are fine. And in those patients, we might need to keep an eye on the fibroids to make sure that the fibroid is not getting worse or getting bigger, or and also we have to assess the position of the fibroid that's not, for example, in the way of having a C-section in the future if the patient is wanting to conceive, for example. But do nothing is one option. A second option would be to have surgery to remove the fibroid, and that's called myomectomy. And that is an option for patients who have not completed their family. And when there is a wish or a plan to have future pregnancies, that can be done laparoscopic or open. I'm mainly specialized in laparoscopic approach, hysterectomy to remove the whole of the uterus with the fibroids, and that's an option for patients who completed their family. Some patients can get they might not see that as a good option because they don't want to anything that can affect hormones in their body. But removing the uterus does not mean that we need to remove the ovaries. So the ovaries can stay in situ, and we can just remove the uterus with the fibroid. And again, that can be done laparoscopic or keyhole surgery. And the third option is, or the fourth option is uterine artery embolization. And that's where that procedure is done by the interventional radiologist, where they use a small wire to go through the blood vessels and find the blood vessel that is supplying the fibroids and try to block that vessel. Most of the fibroids might not be suitable for uterine artery embolization. There is a tight criteria for which fibroid is suitable for uterine artery embolization. And also, we don't know how the uterine artery embolization affects future pregnancies. So that's another element that makes that option not that popular. And the success rate is also varies between fibroid and patients to patients. So it depends on the position of the fibroid. The success rate can vary. There's also modern treatment for fibroids with radiofrequency by basically burning the fibroid. And that is new and still limited to small to medium-sized fibroids.